problem of women of reproductive age. And we as a gynecologist and as an infertility specialist do come across it. So I hope that you will find this presentation useful in your clinical practice. So endometriosis is 7 to 10% is the incidence, but we as an infertility specialist come across it more often. So in infertility, nearly 1/3 of the women do have endometriosis. Diagnosis is often delayed, and what are the reasons? First, presentation is very different. Some people present with pain, other women present with infertility, and in some there may be an incidental finding of endometrioma. So that's why if patient is not coming directly to our infertility specialist, maybe she will have few years till the diagnosis is made. Secondly, the diagnosis is difficult to make because the gold standard is, what is the gold standard? Laparoscopy. So laparoscopy is not available in each and every center, and with ultrasound you can miss it, and that's why often the diagnosis is late. And then of course we don't know what is the pathogenesis. Can we have this mic? Yeah, sure. Okay. So why does it occur? Why some women have it and others don't have it? Stand there. So basically, there are many theories that why the endometrial stroma and glands are present outside the endometrial cavity. And the most common, which we all know, is the transplantational theory, that during periods the blood retrogradely migrate in the pelvis. So regurgitate or goes back through tubes in the pelvis, and the endometrial cells present in the menstrual blood are alive. They can get implanted and then they grow and form a spot there. And this spot is estrogen dependent, it will bleed, it will grow with the estrogen, and when it bleeds, it will result in fibrosis and adhesions. So this is the most common theory, but of course there are other ones as coelomic metaplasia theory, induction theory, and then genetic and immunological responses of the individual. That's why some women have it, because their immune system are weak and they cannot overcome these cells, and other women don't have it. Sites are many, but the most common is ovarian, and then is the posterior pouch of Douglas. And then there are many other like uterosacral ligaments and loops and extraperitoneal, extrapelvic, and less common sites. Now, you can see this. This is why I said that diagnosis is delayed, because not every time you will see the typical classic bluish nodules or some fibrosis there. इसको मैं पढ़ Okay, yes. So this is a typical chocolate cyst, endometrioma, and this is a typical bluish spot which we see when we do laparoscopy. But this is very atypical presentation of endometriosis, and only histology proved that this is endometriosis. So white nodules can be there due to fibrosis. This is old endometriosis, and then there could be deeply sighted endometriosis which can be missed by inexperienced eye. So now the classification of endometriosis. We know that the American Society of Reproductive Medicine has diagnosed our scope, and by this we can divide the disease in minimum, mild, moderate, and severe. So what we do is that when we do a laparoscopy, we will see how many nodules are there and what is the size. So size matters and the size matters. And then we have to fill up. This is the performa. It is easily available on the web. So everyone who is doing laparoscopy for endometriosis or even for infertility should fill this performa so that the care is standardized. And whenever patient goes to another doctor, at least he or she will know that which type of stage she is having. So these are the marks. Okay, how many marks should be? So it will be considered as minimum, mild, moderate or severe. Then another thing which the society developed is Endometriosis Fertility Index. So in the scoring, we only see what we laparoscope is allowing us to see. But in Endometriosis Fertility Index, we combine the demography of the patient. What is her age, how many times she was pregnant before the diagnosis of endometriosis, and of course if there is any other treatment taken. So then we have to tell the patient the benefit of this score is that patient and the doctor will know what are her chances of spontaneous conception after the surgery of endometriosis. So this is another performer for endometrial fertility index. You have to fill that, and apart from the adhesions present, apart from these laparoscopic findings, this is another part of it in which you have to see what is the age and what are the other factors which are affecting her, but for the previous pregnancy and any treatment which she has taken, and then you tell her that what is her score. Higher the score, more chances that she will be getting pregnant after the treatment. Now, presentation varies. Some people, most of the people will present with severe dysmenorrhea and dyspareunia. But then the other one will present with only a cyst. So cyst will be there and their pelvis will be fine. And then today's topic is infertility, so we will be concentrating treatment of infertility which is due to endometriosis. So why endometriosis causes infertility? There are many theories, many mechanisms. First of all, because of the adhesion formation, the natural course of tubes and ovary is disturbed. Sometimes you see kissing ovaries, sometimes we see they are pulled back laterally towards the pelvic walls. So this distorts the normal route of ovum transport, and that's why infertility happens. Then of course with adhesions, tubal motility is affected. And then reduced ovarian reserve. This is the most nightmare of us, that with endometrioma, with endometriosis, and even with treatment, ovarian reserve decreases. And that's why even when these patients come for IVF, the response is poor and we need higher doses of gonadotropins. Then there are hormonal causes, which we see that even when we are able to retrieve eggs, in these patients the quality is not that good because of the many hostile environment of the pelvis. So defective folliculogenesis, luteinized unruptured follicles, empty follicles, luteal phase deficiency, and all these are there. Alteration in peritoneal fluid. This peritoneal fluid is very toxic in these patients for oocytes. There are increased number of macrophages because of the inflammation. You know, whenever there is inflammation, it attracts macrophages, and then prostaglandins, cytokines. So all these factors affect the oocyte quality and also damages the sperm in their motility, their morphology. Alteration of systemic immune response also is a mechanism of causing infertility in these patients. So whenever patient comes to us, we do the workup. In male, we do the semen analysis. Dr. Sabdan Khan has elaborated in detail what should we do and what we see. In women, after the hormonal profile comes the tubal status. So for tubal status, one is transvaginal scan. It is very good, but in endometriosis, it is not that much effective. We have to combine it with Doppler, and of course, the laparoscopy is the gold standard. It can see and treat at the same time, and of course, when we enter, we have to see each and every organ in detail. So it helps in diagnosing what is the extent of the disease and what is the severity of the stage. And then we have to see we go in, see the anterior pouch, then we see laterally tubes, then we see posterior pouch, whether it is obliterated, there are adhesions there or not, and then of course bladder, bowel, and till the liver. So uterine manipulation of course help us to see the posterior pouch. Transvaginal scan is good but not very good to diagnose endometriosis, but for endometrioma it is highly sensitive, 83%, and specificity is 98%. So for endometrioma it is very good. And of course we combine doctor with it. I think Dr. Safdar Malik will elaborate more on this role of radiological techniques for infertility. CA125, we do it just to see whether it's an active disease or not. So, minimal mild disease we find 14 to 31 units, and in moderate to severe 13 to 95 units. So, if it's in active disease, we can delay the IVF, we can give her some hormonal therapy, and then we delay the IVF for at least 3 months. So, at least she should be in the recovery phase when we do IVF. Now the treatment options, and I will be talking specifically regarding IVF, regarding infertility. So the treatment options are many, medical and surgical. In medical, most treatment is hormonal. So we have combined oral contraceptive pills, progesterone only pills, implants. Then we have GnRH and analogs, then serum and selective progesterone receptor modulators. But what is the problem with this medicine, with this therapy? Is that we cannot get pregnant when we are on hormonal treatment. So then what can we do for these patients? Surgery is another option, and in surgery we have laparoscopy and laparotomy. Laparoscopy is of course more favored as it has less trauma to the patient, recovery is very early, hospital stay is less, and we can see and treat at the same time. But sometimes if endometriomas are big, if there is frozen pelvis, if expertise is not available, then of course we have to go for laparotomy. So now the guideline says that operative laparoscopy is better than diagnostic laparoscopy alone. So what can we do in operative laparoscopy for endometriosis? So if we see endometriotic spots there, it's better to ablate them and of course do the adhesiolysis, hoping that this will improve her fertility and the tubal motility and the involvement of the pelvis. Now this type A level evidence is good for mild to moderate, minimum to mild disease, which is stage 1 and stage 2. But for stage 3 and stage 4, there is no evidence that this will improve the fertility outcome, because I think damage is already done and they were not able to randomize it. For randomization, I think more of ethical issue was there, that how can you find a patient with stage 3 and 4 disease and not treat it. So this was the problem, controls were not available. So laparoscopic ovarian cystectomy is recommended if the cyst is more than or equal to 4 cm. Previously, ASHRAE guideline 2013 said if the endometrioma is 3 cm. So this is the latest 2022 guideline, which says that if the endometrioma is 4 or more than 4, then it should be removed. And this is superior to incision and drainage. And there are multiple benefits. One, diagnosis is confirmed. Second, the progression of the disease, the size of the endometrioma is reduced, the pain is reduced, and of course the ovarian response is better. But of course, in counseling, and this is for my younger doctor, you should always tell the patient that there is chance that her oophorectomy can be done at the time, because she will be under GN, she will not be able to give the consent. If the endometrioma is big, there are chances that there is not much ovarian tissue is left, and she will have oophorectomy. So this was another treatment which we used to do it, but it did not get very popular. transvaginal ultrasound guided drainage of endometrioma, and then we usually inject it in methotrexate or ethanol, so to prevent recurrence. But as the cyst wall was not taken out, usually we see that cysts do form after 1 or 2 months. So high recurrence rate was associated with this procedure, although it was very less invasive as compared to laparoscopy and nephrotomy. And complications which we saw were infections, abscess formation, and pain, inability to rule out any malignancy, and risk of pelvic adhesions. Now, medical therapy, we as infertility specialists and as a gynecologist are very much in favor of suppression of endometriosis. So usually we give some hormonal therapy, assuming that it will suppress the endometriosis, and then we start the infertility treatment. But there is no level A evidence about the benefit of giving hormonal therapy before the laparoscopy or even after it, and it does not increase the live pregnancy rate. Post-operative hormonal treatment has no beneficial effect on pregnancy rates after surgery, but it do improves pain. So if pain is only the presentation, not the infertility, then of course we can give it. But for improving infertility, it has no evidence. So what NICE says? NICE says to treat women according to her wishes, her symptoms, and of course her fertility desire. So you do not treat by the stage of the disease. You treat what are the women's symptoms and her preferences. Choice of treatment, among all of these treatments which are available, then we have to tailorize our individualized treatment, and we have to take account the patient's age, of course symptoms and her desire, and then we have to see what are the risks of the treatment, side effects, and cost is of course is the topmost in our priority. But usually what we do is that for endometriosis, all the guidelines say that artificial reproductive, assisted reproductive technique is the gold standard. So we should go earlier than later to ART. Now in ART, IUI, although it has very low success rate, but it is very economical, easy to do, no expertise is required, and usually it is available in smaller centers. You don't need to refer patients to the specialist centers. So it improves fertility in patients with minimal to mild disease, and especially if it's combined with ovarian stimulation. But poor ovarian response and need for high GnRH analog injections you should be keeping in mind. So cost may be more than the normal IVF. IVF is appropriate treatment, especially if there is tubal factor, tubes are blocked, if there is male factor, or if we have tried IUI and some other treatment and it has failed. So treatment with GnRH agonist for 3 to 6 months before IVF in women with endometriosis increases the rate of clinical pregnancy. Now this is the ISHRAE guideline. The RCOG says that there is no difference, so there is no need to give hormonal therapy before or after the laparoscopy or before and after the IVF. But the ISHRAE guideline says that we should give 3 months of hormonal therapy, usually GnRH analog, because it suppresses the endometriosis. And usually this is the common practice. So, should we do the surgery before the IVF or should we not do it? So, what things we should keep in mind? We should do AMH of the woman, and if it is very low, we should be prepared that it will further decrease after the surgery. Progressive decline in ovarian reserve. Definitely, low AMH means that the ovarian reserve is also lowering. High gonadotrophic consumption. So this is our routine practice. Normally, if the infertility is because of the tubal factor or some other reason, by the 9th or 10th day, woman is ready and we start trigger. But in endometriosis, it takes up to 14 to 15 days for the mature oocyte to reach, and then we give trigger, so more longer action and more longer treatment. Lower number of oocyte retrieve. Unfortunately, with these higher doses of gonadotropin, still we only retrieve 3, 4, a maximum 5 oocyte because their reserve is low and we are unable to get more number of mature oocyte. Now, risks of surgery should be in our counseling. We should tell the patient, and of course, we as a surgeon should keep that in mind. So, 3 to 10% chances of damaging the surrounding structures because of the adhesions. Already, adhesions are there, bowel, bladder, ureter, so they can get injured. Risk of oophorectomy, as I told before. Complete excision of endometriotic tissue may not be possible if they are deeply seated. May not reverse the inflammatory and biomolecular changes. Of course, the genetics of the woman is the same. So you treat it, and after a few months, maybe there will be new implants formed there. So this will be kept in mind with the patient. Normally, patient asks when दोबारा तो नहीं हो जाएंगे. Of course, you have to justify your answer. Okay, yes, there is a risk that it will reoccur, but of course, it will depend on the treatment and on the what was the extent of excision. That maybe it will take longer, and you will get a window in which you can get pregnant. And of course, expertise are required in laparoscopic adhesiolysis and everything. So complications during and after ovum pickup. So not only the surgery is difficult in these patients, even the ovum pickup is very difficult because of the distorted anatomy of the pelvis and adhesions are there, and sometimes if the endometrioma is less than 3 cm or 4 cm, then we are doing ovum pickup with the endometrioma still there. So technical difficulties during oocyte retrieval, if the endometrioma is coming first and oocytes are lying behind the endometrioma. Risks of infection formation as endometrioma, if we rupture this endometrioma, sometimes there is abscess formation. And of course, if we rupture the endometrioma, this fluid is very toxic for oocyte. So follicular fluid contamination by this endometrioma fluid. In the context of IVF treatment, delaying surgery for a few months should be considered. As I said, we can give GnRH analogs and then do the IVF. So few months will do no harm, but the patient's health and the condition of pelvis will be better. So what are surgery recommendations? Directly do IVF or surgery before IVF. So I found it very helpful that if the patient is asymptomatic and you have found even stage 4 disease in her, or women of advanced reproductive age, then those with reduced ovarian reserve, AMH 0.01, 0.05, and then bilateral endometriomas, a history of prior ovarian surgery. So IVF is better than the second surgery. So all these patients, if you come across these patients, it's better to refer them for IVF. There is surgery will do more harm than good. And surgery before ART in those patients who are highly symptomatic women, of course, if pain is unbearable or they are having bigger endometrioma, but it should be unilateral. Intact ovarian reserve, they are young patients and they have good AMH. And cyst with suspicious radiological and clinical features, if you are suspecting malignancy in those cysts, then of course you have to do surgery first. So this is a very good summary in which we should go for surgery and in which we can go for IVF directly. And as I said that they have seen that the second surgery does not improve IVF outcome, so it's always better to go for IVF than for the second surgery. But again, you have to individualize whether your patient is symptom-free and endometrioma is small. Sometimes you have to do second surgery if endometriomas are too big. So take-home message, medical therapy does not improve fertility, unfortunately. Surgery improves the chances of natural conception. Surgery does not improve the success rate of IVF. Now this is very contradictory statement. It does not improve the success rate of IVF, but it do improve the chances of conception. So we should treat it, although there is no evidence right now, but hopefully we will be able to generate an evidence by our own center. So immediately after surgery is the best period to conceive, and that's why although they said it's the best period to conceive naturally, but I would like my patients to go for IVF in this window. Take into account overall fertility picture, age, symptoms, previous surgery, etc. Thank you very much.
For this appointment, call us on +92 320 2233 074.